Wir kommen dann weiter zum fachlichen Programm mit Herrn Mestanoglu aus Köln. Er wird sprechen zum Thema das Geheimnis der kornealen Neovaskularisation. Ich darf Sie nach vorne bitten und Sie können mit Ihrem Vortrag beginnen.
So today I will talk about the mystery of corneal vascularization. Since the time of Galen, or since also almost 2000 years ago, we as humans were aware that cornea is avascular, but it was only until last century we came up with the idea that this avascularity is maintained by a balance of anti-angiogenic and pro-angiogenic factors, and when this balance is lost, the cornea is invaded by blood and lymphatic vessels. And indeed, as we identified these targets one by one, we could see this corneal avascularity is redundantly organized, and one of the big findings on that came when Professor Kurziefen and colleagues showed that corneal epithelium also expresses ectopically VEGF receptor 3, therefore acts as a decoy receptor for VEGF molecules and inhibits corneal angiogenesis. And shortly after that, there was another study that showed the role of soluble VEGF receptor 1 by studying the only mammal with physiologically vascularized corneas, so the manatees, or so-called the sea cows, which physiologically don't have a mutation, the soluble VEGF receptor 1, therefore do not express it, whereas their closest familial member on land do have this molecule, therefore has an avascular cornea. So through this evolutionary approach, we could identify that this soluble VEGF receptor 1 was identified as an anti-angiogenic molecule. And in times, we now know that there are many anti-angiogenic factors, such as the soluble receptors or thrombospondins and so on, and pro-angiogenic factors such as the VEGF molecules and interleukin-1 and metalloproteinases and so on. But this injury or insult that causes corneal neovascularization can have different reasons, such as inflammation or keratitis, whether it's bacterial or viral, as well as chemical burns or genetic factors such as aniridia, or autoimmune and hyperimmune conditions and trauma. And the incidence of corneal neovascularization is reported to be as high as 1.4 million cases each year. But not all of these corneal neovascularizations are clinically meaningful or important, but it's important in terms of when the patient needs a keratoplasty. And through a meta-analysis, Professor Bachmann and colleagues could show that the corneal neovascularization is the main risk factor for an immune rejection against the corneal graft, and as the vascularized number of cornea increases, so increases the graft rejection risk. And the same is true for the graft failure rates, and as a conclusion, they concluded that the presence of recipient neovascularization was found to increase the risk of a future graft failure by some 30% and more than doubling the risk of a graft rejection. And the latest results from the longest study from the Australian graft registry also shows the same pattern. So, for example, when the corneal transplant was performed to a non-vascularized recipient, after 10 years, the risk of a graft rejection, the graft survives up to 68%, whereas once the cornea is completely vascularized, the cornea can only 26% of the corneas can survive. And then Dr. Dietrich and colleagues showed that actually lymphatic vessels are more important in terms of graft rejection than blood vessels. So in this case, the grafts with the corneas without lymphatics but with blood vessels only decreased the risk of a graft survival by slightly, but in terms of when there was also the lymphatic accompanying vessels, the risk of a graft rejection was increasing significantly. And what treatment options do we have medically in the clinic against corneal neovascularization? So the most common used drugs are corticosteroids and the anti-VEGFs, but of course they come with certain risks. And corticosteroids are well known to increase intraocular pressure as well as induce cataract formation and make the cornea more susceptible to infections. They also suppress the wound healing, and anti-VEGFs have the same effect on the wound healing as well as the rare risk of limbal stem cell deficiency or corneal nerve dysregulation. And furthermore, anti-VEGFs are effective in preventing new vessel formation, but they are not effective against the already established vessels, because in this case there are other cytokines present other than VEGFs, and once the capillaries are covered by pericytes, they are becoming less dependent on VEGF molecules. And this was also priorly shown in IOES that early or mid-term bevacizumab injection is effective against inhibition of corneal neovascularization, whereas the late treatment is not effective. Therefore, we only have two established methods for regression of already established vessels in the cornea. One of them is the photodynamic therapy, and the second is the fine needle diathermy, or the thermal cauterization of these vessels. But photodynamic therapy is expensive and it's time-consuming, and it has some potential side effects due to laser irradiation, whereas the fine needle diathermy induces rebound neovascularization because the treatment itself is increasing the expression of VEGF. Therefore, we did priorly a study on fine needle diathermy combined with subconjunctival bevacizumab injection that had 31 patients at start, which showed some promise in terms of decreasing the immune rejection after this high-risk keratoplasty. And the early results were promising, as after 1 year, there was over 90% of graft survival, but this study lacked long-term follow-up, which we did report actually recently, and in this case we could see that almost half of the grafts had an immune rejection in 3 years follow-up. Therefore, the conclusion is graft survival is similar to untreated eyes with corneal neovascularization. So therefore, as a new method, we were working on UV light cross-linking, which in experimental studies we could show that it regresses mature corneal blood and lymphatic vessels in mice, and then which you can here assess by the blood vessels stained by CD31 and lymphatic vessels with live-1. And we could also see that it promoted the graft survival in the subsequent corneal transplantation. And then we translated this findings with a small pilot study where we had 5 patients went through cross-linking first to achieve vessel regression, then followed with high-risk keratoplasty. Here some patients had peripheral thinning of the cornea, which therefore they were not suitable for fine needle diathermy. And in some cases there was active keratitis, which Professor Behrens already explained that it is a good method because of the antimicrobial effects of the cross-linking. And in this study, we could see that 70% of the vessels were regressed after this combined treatment. And this effects of this treatment was lasting for a certain point. So in this left image, you can see an eye before the treatment, and in the middle, after 6 weeks, the blood vessels has regressed, and we couldn't see any meaningful vessel regression after 15 weeks after the surgery. So as a short summary, the cross-linking was effective in stabilization of the tissue as well as vascular regression, with the possible improvement of the graft survival, which because we did not see any immune rejections against the graft in these 5 cases. And we have started the BMBF-funded prospective multicenter study already, which I will explain more in detail in a second after explaining one latest method, that is the combined cross-linking and fine needle diathermy. So in this case, we had the idea maybe both methods have an even greater effect in regression of the vessels, and it was indeed as we expected, especially in the cases of the lymphatic vessels, which you can appreciate in the right side, that had even a greater effect than monotherapies of cross-linking or diathermy. And we also did some pilot studies in patients as well, where patients had some first fine needle diathermy treatment, followed by cross-linking, and at the end, high-risk keratoplasty. But so far, these are unpublished data, and I can say that we can see significant regression of both blood and lymphatic vessels, accompanied by reduction of inflammatory cells. And our pilot data in patients is also promising. That appears to be a safe and effective method for this purpose, and therefore controlled trials are needed. And here I explain about the study that is called cross-corneal vision study, where we examine UV light-mediated corneal cross-linking as a lymphangioraggressive pretreatment to improve graft survival after subsequent high-risk corneal transplantation. This is a prospective randomized multicenter exploratory study, and as I mentioned, we have the funding from the Federal Ministry of Education and Research for 5 years of an amount of almost 3 million euros. And the study design is basically, we will recruit 110 patients in the next 2 years based on the inclusion and exclusion criteria. And the patients will then randomize to a 5-to-4 in a 5-to-4 manner, where treatment arm will be composed of 61 patients and the control arm of 49 patients. And in the treatment arm, there is also some recent changes based on our pilot data. We first decided to, if there is a necessity, there will be the application of fine needle diathermy followed by high-risk keratoplasty, and finally the cross-linking of both host and the donor tissue, so without epithelium, so after the abrasion of the corneal epithelium and after suturing of the graft, in order to also modulate the antigen-presenting cells of the donor tissue. And in the control treatment, the patients will only receive high-risk keratoplasty. And 25 of these patients will be treated in our clinic, and the other 85 will be by the external centers of Berlin, Düsseldorf, Erlangen, Freiburg, Homburg, Munich, and Rostock. And follow-up examinations will be performed at regular intervals and up to 24 months, and possibly then later as well, where the outcome criteria is established as graft rejection and survival and function with corneal neovascularization areas and best corrected visual acuity and life quality of the patient. So if you have patients scheduled for the high-risk keratoplasty, you can contact our clinic or the participating centers. And thank you for your attention.
Thank you for your presentation. Are there any questions or remarks from the audience? That's not up to now. From the chat, we have the question in the first part of your presentation. You told us that you performed cross-linking prior to penetrating keratoplasty. How long was this before?
So yeah, that was the first tried method, so to say, and then recently, so we tried both methods, so without keratoplasty, so combined diathermy and cross-linking, and then keratoplasty at the end, and then also the method of first diathermy in the middle, keratoplasty, and at the end cross-linking. And so far our data shows this method, that having the cross-linking at the end is the most promising one, and also it has the possible effect of, as I mentioned, modulating the graft from the graft immune cells as well. So there we expect an even better effect on graft survival, since through this method we can also hopefully decrease direct sensitization of the against the graft. So that is the idea that led to us to this change.
And another question, do you have experience, or does anybody here have experience with bevacizumab eye drops?
With the
bevacizumab eye drops.
So there was a recently published clinical trial from Boston that had the patients received subconjunctival bevacizumab after at the end of high-risk keratoplasty procedure, and then they received bevacizumab eye drops for up to 1 year, which they did not see such an effect, but only in the lead study center. So they can probably find that under the name of Dolman. that was published this or last year.
Dr. Mestanoglu, I think I missed this differentiation between different types of vessels. I think we see clinically a clear difference whether we have a limbal stem cell deficiency. When we do a keratoplasty there, the vessels grow over the graft, and we cannot stop them often with steroids and with whatever. But on the other hand, if we have a clear reason like an HSV keratitis with compensating vessel growth to the center once we do the graft and treat them with antivirals and steroids, the remaining vessels on the host, they regress. So there must be a difference between these types of vessels. I think vessel is not vessel, or how do you explain that?
I mean, based on the etiology of the corneal neovascularization, there are definitely different vessels, and as in the case of Professor Behrens, that cross-linking is maybe not effective against some, for example, Candida. In our case, maybe this is not also effective for all types of corneal neovascularization. So maybe in case of chemical burn, our method is more effective, or some others are not effective. So in this case, we need more patients' numbers based on etiology to see maybe on this terms, it is not only by the blood vessels, but also the whole immune system that includes T-cell response and so on as well. So therefore, in different etiologies, we have maybe the same vessels as an appearance, but the immunologic profile of these cases are different. And actually, we have a study on that is under revision in IOES, as far as I believe, that we actually have different immune profiles of cases of corneal neovascularization and chemical injury, for example, or suture-induced inflammation or so on. So therefore, not a single treatment might be the best option for each case of corneal neovascularization, and we might need to specify for example, for chemical injury, this might be the best option, and for herpetic keratitis, that might be not.
Sorry for saying that, but chemical burns makes limbal stem cell deficiency, and limbal stem cell deficiency vessels have a bad prognosis. I'm not sure. I think you should really differentiate in this study where we are taking part according to the limbal stem cell deficiency 2 quadrants or non-limbal stem cell deficiency. I think this is very important.
Yes, that is definitely one topic that should be covered during inclusion or exclusion criteria, or a subgrouping of the patients, that otherwise, we definitely need a sub-analysis of etiology of the corneal neovascularization. So that is that we can further discuss with Professor Kurzifan, yes.